I'm Rebecca Canino from Johns Hopkins, and I am joined here with Dr. Helen Hughes, Medical Director, Johns Hopkins Office of Telemedicine. Online, we have folks. We're trying to maintain and look at the chat, but
Bill England.
Yes, Bill England is going to be moderating online and making sure that we know if there's any questions coming online.
We see your question. We are all waiting for the host to open. So I think it is open.
Yeah, we're open now.
Great, fantastic.
Yay!
People are populating. We got about 10 or 12 of us online.
Oh,
Great.
yay!
Your voice is coming through loud and clear, so that's awesome.
Okay, this is fabulous. All right, so we are going to take a very relaxed approach to a very important topic and kind of talk through something that's near and dear to everyone's heart here, which is equity. And you've been hearing it over and over again in every session we've been in. And it's a very strong focus for Hopkins. And so I'm going to ask Helen, how did you even begin to approach this? And she's going to go through her slide deck. We are going to have some polls in it, and then we're going to open it up for discussion. So our goal is that everyone's very comfortable raising their hand, jumping in, and making this interactive. All right, Helen, want to tell us about your equity experience?
Yeah, this is a big topic, so thanks so much. Just a little bit of a preamble. Clinically, I'm a general pediatrician. I practice in East Baltimore. 95% of my patients are Medicaid enrolled, so my pre-COVID interest in telemedicine was really around access and equity. And so we're going to talk a little bit about our experience by the numbers, but it's certainly been great to see telehealth expand at Hopkins, but also hard to see it be difficult to access for some of our patients in East Baltimore. Huge thanks to our team. This slide deck is a collaborative effort. We don't have any disclosures. We wanted to start off with a poll just to get a sense in the audience. If you can go into your app, we wanted to ask, to what extent do patients in your organization face barriers to telemedicine access? And Rebecca's going to help us summarize.
So Helen, how would you answer this question for us? No barriers, minor barriers, some barriers, significant barriers, or severe barriers?
I would say significant barriers for some patients. Oh,
nice. Okay. Things are rolling in. I think down at the bottom, there was a thing called polls.
And then you'll see the result as you answer. Lotta, I see people helping each other troubleshoot. That's great.
See.
All right, so we'll give the poll maybe 30 more seconds.
Yes.
Yeah, how's the poll going? Everyone have access to the poll?
Okay. So far, not a single participant has said there's no barriers to telemedicine access. That seems across the board, and we are at 71% significant barriers. Okay, we'll keep that going and come back to it.
Okay, excellent. So we're going to overview our state at Johns Hopkins to give you a sense of the experience at our organization, and then we're going to talk specifically about some efforts in Baltimore City to address the disparities that we've seen. So this is a summary slide of our ambulatory telemedicine experience at JHM. We have had an Office of Telemedicine since 2017. Rebecca was one of our founding members, leaders, and we had a pretty small outpatient footprint pre-COVID, which is probably similar to a lot of groups, but we had fewer than 800 ambulatory visits. Big expansion during the initial months of COVID. Video here is blue and phone is orange. We've now had over 1.5 million visits, and we have about 30,000 per month across our health system, which is about 15 to 13% of our outpatient care volume. This is by specialty, looking at telemedicine sensitive visits, so excluding lab and radiology and things that would need to be done in person. What percent of our outpatient care is done by ambulatory telemedicine? This is divided by halves of the year. So blue is the first half of 21, yellow is the second half of 21, green is the first half of 22, and orange is the second half of 22. It's been interesting that nutrition has pulled into #1 spot in the second half of 2022. We have now psychiatry, so we've certainly seen psychiatry go down from about 82% in 21 to now 55%. We still have critical care, which would be mostly pre-op and post-operative for anesthesia, neurology, neurosurgery, genetics. I'm still doing a fair amount of outpatient telemedicine. And then in some of our subspecialized surgical specialties, they never were doing a lot and still have pretty low volume.
So Helen, 1 second. So for those of you in the room and at home, does that ring true for your own organizations? Does that kind of spread of telemedicine across the specialties? Is that what you're seeing? Any of that?
Hand raise if that's similar to what you're seeing at your organization.
Yeah.
Few.
Okay.
Okay, great. I can't see, I don't know if you can log into the chat, but you're on the polls, so. Okay. Great. Well, we did survey our providers in 2021, all of our providers who conducted telemedicine. We had 1,300 responses. And certainly patient internet connectivity and video connection, audio connection issues were one of the top barriers, which is not a surprise given all the equity issues we're describing in this conference. And so we, in the fall of 2020, about 9 months of the pandemic, did create an equity dashboard to try to map in real time what we were seeing. We described this dashboard in the Journal of Healthcare for the Poor and Underserved, how we created it, and we also established a telehealth equity working group that's been meeting monthly for about 2 years now, mostly of digital health equity researchers across our School of Nursing, Public Health, and also our Office of Economic Development and Community Partnerships. It's been really great to learn some of the lessons learned from our research groups who are working in digital literacy training programs and deploying technology in underserved communities and try to translate some of their knowledge into operational change. This is a screenshot of this dashboard, and I'll go a little bit more in depth into the data in the next couple slides, but of our about 1.5 million visits at the top left, you can see 84% have been by video and 16% by phone. And then the dashboard breaks down visually by different patient demographic groups, whether visits have been conducted by video or phone. And this is all encounter level data, so not patient level data. Important to note how we determine whether it's phone or not. I know there have been difficulties analyzing, as was mentioned in the keynote this morning, analyzing audio-only visits. This is based on whether the provider indicates that it was a telephone visit at the time that the visit was closed. We schedule all of our telemedicine as video visits, and so this is really the provider indicating that it was done by audio-only or telephone. So I will just summarize the data a little bit here, visualize a little more cleanly. We have seen of encounters with patients who have in the EHR identified as Black or African American race, higher rate of telephone encounters in comparison to white race. On the right, number 2, preferred language, higher rate of telephone encounters among patients Spanish speaking versus English speaking, higher rate of telephone encounters in older adults, and then pretty significant differences by payer. 7% of encounters were privately insured patients by telephone versus 27% for Medicaid and 25% for Medicare. We have a map, which is a heat map by zip code. If a zip code, if the encounters were 0% by telephone, it's dark blue. If the encounters were 50% by telephone, it's dark orange. In Baltimore, we see in East and West Baltimore, there's a butterfly pattern of many socio-demographic disparities, but we see higher telephone rates in those areas. We can ask you a question?
Yeah, but do this one first.
Okay, great.
Yeah.
Then just looking among adults age 65 plus, seeing those disparities to be even starker, with some neighborhoods in East and West Baltimore having over 50% of encounters by telephone.
So I was just going to ask the audience, when you look at a map of your region, how many folks in here are in Maryland? Besides, okay. So for our rural folks, just looking at how you can see the colors light up in your rural areas and in your urban areas, some of those shared challenges, and maybe the barriers are a little different, but it's so fascinating to me to see those bright spots in our rural zones, I'm looking at Sarah over there, and in our urban zones.
And I know others were on a call yesterday with California, and I know other organizations have dashboards similar to this that have showed similar disparities. This is just for those who aren't familiar with Baltimore City, just zooming in on a few zip codes. 21213 and 21210 are neighborhoods just to the north of Johns Hopkins Hospital with a median average annual income of $39,000 versus Roland Park is 21210, much higher average income. And the top is all ages. The first column is all visits, percent of all visits that were by telemedicine. So you can see all patients had about 17% of encounters by telemedicine. Actually higher rates of use of telemedicine in those zip codes just north of Johns Hopkins Hospital. But if you look at the percent of those telemedicine visits that were by phone, we see much higher rates of phone visits versus in that more affluent area, lower rate of phone visits. And then even if you look at over 65 plus, pretty evenly distributed amount of telemedicine in comparison to in-person care in all of those zip codes, but pretty significant differences in whether it was accessed by video or phone. And that also maps to the wired broadband access in Baltimore City. Unfortunately, haven't seen, that is data from essentially over the past 2.5 years, but we have not seen the disparities go away. We've perhaps seen minor differences over time, but this is data looking at 2021 first half, second half, and the first half of 2022 that we have visually just seen pretty persistent disparities in these video versus audio only access. Okay, so I think we're on our second poll question.
All right, you ready? Does your organization have any programs addressing access to telemedicine in any of the following areas? Internet access, device access, digital literacy, other. All right, Helen, you answer for us.
Oh, sure.
All right. This is kind of fascinating. So it looks like folks are really zoning in on digital literacy. I'm so curious as to what some of the others are. If you are online or in the room and you clicked other, would you like to share?
What if you don't have any programs?
Good point. We could have put a none category. So other could be nothing, but or you could not answer the poll, but we don't see the end. So
Okay.
good statistical feedback.
Yeah, thank you. Someone should hire you for that brilliant brain.
Hi, my name is Brittany Walden. I'm from UNC Healthcare. I work in the virtual care center. One of the things that I would probably classify as other but it kind of touches on some of those other areas is one of the things, and you guys may have noticed this with COVID, is connecting. You're always going to have challenges. They're not always on the provider side. If you can stabilize those, but then you may have issues with patients with certain comfort levels. So one of the things that we are kind of piloting with our one virtual practice that's primary care is something called a patient support program, and it's folks that are CMAs and CNAs, but trying to find folks that are more tech savvy, and they call the patients ahead of their visits and kind of make sure that they're getting through all the steps to get to their video visits. And we've seen a really great amount of success with that. The providers have told us multiple times, in my other clinics where I do this, I still have issues, but when I come in practice here, I don't have those issues. So kind of like bridging that gap to help the patient through is what I would probably classify as an other area.
So like para-patient support?
And hi, Brittany, this is Nikki from UVA, and we stole that idea after talking to them. And we do that with what we thought were high, clinics that were really dependent on trying to get it. So transplant's one, because they have 4 visits, and so if it fails the first one, that whole day is lost. And so I remember when we spoke, I was like, wow, that's a lot of work, and we totally works for that small population when you need it.
Awesome. I love this.
Yeah, I think we've had a couple of clinics that have sort of virtualized and become virtual predominant, and they've found it easier to recruit support staff who are mostly virtual and or from home, and that those support staff really, really help the clinic run more smoothly and help the provider and the patient satisfaction. Okay, great. So we wanted to give a little bit of sense. We've been very engaged in the AAMC subcommittee on telehealth and subcommittee on telehealth and healthcare equity. We received a AAMC Telehealth Equity Catalyst Award for some work around convening some discussions in Baltimore City. And so we wanted to give a little bit of sense of our awareness of the national landscape. I'm sure lots of people in this room are also working in this area, but just to give you a sense of who the AAMC Tech awardees, if you weren't aware of these groups, this was awarded last year. UC Davis has a project evaluating virtual family-centered rounds for patients in the NICU with a focus on LEP patients and determining how telehealth could be used to improve access to virtual rounds for patients and parents who are non-English speaking. MUSC has their telehealth-based free clinic with primary care for people experiencing homelessness. University of Arkansas has a telesane project using telemedicine to do SANE exams for sexual assault nurse examiner exams throughout Arkansas. Oregon Health Sciences University has a patient portal simulator to help patients practice in the full patient portal environment and as well as get patient feedback. MUSC has also a virtual reality simulator for patient access and engagement. And Henry Ford Health System has a program expanding and enhancing their on-demand virtual care for older adults and improving access there. One group that we've had initial conversations with who seem to be working nationally in this space is North Star Digital Literacy. They are a group out of, I believe, affiliated with the Minnesota Department of Health. They have this great URL, digitalliteracyassessment.org. They have a freely available digital literacy assessment. And this is a free online program that can test users' basic computer skills. And then they have some great freely available curriculum, like what is a USB port? What does a USB, I don't even know how to describe it, but the part that you put in the port, how does that work? So this is a great resource that we are considering partnering more with for some of our efforts. So before we talk a little bit about what we've done, if anyone wants to speak, if Rebecca is willing to bring the microphone around about what efforts, we heard a little bit in the polls, but if anyone wants to talk a little bit more about their efforts in telemedicine equity, that would be great.
Anyone want to share? We already saw one example of how sharing jumpstarts other programs.
Well, maybe we can go first, and then we'll see if
perfect.
Sounds great. Okay. So we wanted to walk through some of our collaborations for community-based interventions, and this is all to say it was hard for me personally to know whether to have a telemedicine equity dashboard. We launched this in maybe the fall of 2020, and it is available to anyone in our health system, administrators, frontline providers. We suspected we were going to find disparities, which were not entirely surprising to us, but didn't necessarily have a plan for intervening upon them. So it was hard to know whether to launch a dashboard that we didn't have a plan to fix the disparities that we would see. But I think we found that even knowing about the disparities and being able to articulate them to our institution's leadership, to be able to articulate them to leaders in cross sectors in Baltimore City has been very helpful. From a policy standpoint, it's been helpful to be able to articulate what we're seeing in our patient populations and being able to slice and dice by different specialties and payers. So what I'm going to describe next has sort of arisen organically, and we're trying to use this AAMC award to help formalize it a little bit more. So we were able to use the dashboard information and present it to the Maryland legislature, who did pass the Preserved Health Access Act of 2021. That made permanent for Maryland Medicaid home as an originating site and also continued reimbursement parity and audio-only reimbursement. And then there is the Preserved Health Access Act 2023, which has made it through almost every part of the Maryland legislature and is likely to be passed. And so that will give us another 2 more years of the current state for Maryland Medicaid. And then also, discussing with our regional partners, and we're excited to potentially have an event next year, so stay tuned, around cross-state care continuity, and it's been really great to see all of the innovation across Maryland, DC, and Virginia in that space. And then federally, we're able to submit data to US Congress and CMS and engage with the Alliance for Connected Care, and published a piece in New England Journal around our audio-only care and its use beyond primary care and behavioral health, which I think is often where it's thought of being used, but we've seen a lot in specialties like oncology and cardiology. And as likely all in this group are aware, it's been great to hear about a lot of the coverage flexibilities through CMS continuing for the next 2 years, and then adjusting to the very complex changes around the PHAH expiration. But we're excited that generally we feel like we have about 2 more years of telehealth at its current state. But a big North Star or guiding star for us has been the VA program. Do we have any VA people here? I know we had one earlier. Through our work with the AAMC, we learned a lot more about the VA's Anywhere to Anywhere program and how, in an access crisis for veterans, they really mobilized to address multiple areas of internet access, device access, training, as well as policy to use telehealth to improve access to care for veterans. So we've been thinking about how can we take those building blocks that the VA has used and try to recreate that regionally in Baltimore City and kind of catalyze momentum in each of those areas, because it would be hard for us to, nor do we want to, address this for our own patients in a vacuum, because really telehealth is just a small slice of their life. And we have issues with, even if we could have devices, we can't just be giving devices to all of our patients for a variety of reasons. So from an internet access standpoint, we've been speaking with Baltimore City, who has a digital equity officer, and the East Baltimore Development, Inc., who's been doing work on internet access in East Baltimore, and thinking about how we can link our patients to these programs and also potentially apply for federal grant funding like the ACP program. For device access, we've been having conversations with our local library system, who has a lot of devices that they actually have trouble distributing, as well as our Office of Economic Development, thinking about, again, how can we link patients to these programs or bring these programs to our patients in places where they already come. From a digital literacy standpoint, we've been working with our Office of Economic Development and our School of Nursing, who has a lot of literacy training programs. And we have an exciting collaboration where pre-health professional students, and particularly nursing students, will be going to community-based events to do digital literacy training. And we are thinking about doing that iteratively. We have a blood pressure screening that happens in Northeast Market, which is down the street from Johns Hopkins Hospital, every 2 weeks. So it's really exciting to think about how could we be doing iterative trainings there where people knew that they could come back there if they needed more help, and also the possibility to link maybe device access or ACP sign-up programs at that location. From a digital health design standpoint, we're trying to leverage more diverse patient feedback in our design system. I'm sure everyone has experienced a whirlwind over the past few years, but trying to take a deep breath and figure out how to get more inclusive design, as well as design of patients who don't speak English into our system. And then also talking with our colleagues in Maryland from a health system standpoint and our government affairs team around advocacy for the Maryland legislature. And so what does that look like in time? We have our working group that meets monthly and work with our Office of Economic Development on this digital training program monthly, sitting on this East Baltimore Development Equity Initiatives bi-monthly. And then you can speak a little bit more. I think we have a slide later on the event with Yale and University of Maryland. And then our AAMC Tech Grant Convening Session will be in June. And so those who are Maryland or Baltimore based are welcome to come. Please let us know if you'd like to come. And we'll be asking for your feedback about that in a couple of slides.
Okay, now we do have a question from one of our virtual participants. So Madeline asks, do you know where we could look for funding for getting internet access for more of the rural areas? And we have 3 good sites. So affordableconnectivity.gov is one. You can also go to the www.whitehouse.gov/getinternet. is another, and then cnm.universalservice.org. So those are three good connection points. Yay! Oh, good. I'm getting. Yay! Yay! Nice. Okay. So actually, do you mind talking about it for a second?
Yeah,
We
that's
good?
great.
Yeah.
My elevator speech.
Yes, please.
So we administer the rural healthcare program through Universal Service Administrative Company. This is an FCC program that we administer for the FCC. There are two programs. There is the telecom program and there is the Healthcare Connect Fund program. The easier one to explain, frankly, is the Healthcare Connect Fund program that was launched in 2012 that funds 65% of broadband services, advanced broadband telecommunication services, including basically the broadband that comes to the brick and mortar eligible healthcare provider, as well as the equipment such as routers, switches, and firewalls that make that circuit functional, as well as some infrastructure costs, so a flat 65% discount. The other program is the telecommunications program, and that was established in 1996 through the Telecommunications Act of 1996. And it funds the difference between what people pay in urban areas versus rural areas, so that the people in the very underserved rural areas pay no more than the urban areas in their state for same or similar services. There is also a very exciting pilot program right now that the FCC is hoping, if it is a success, will turn into a regular program, which is the Connected Care Pilot Program, and that is really exciting. They've selected, I think it's 104 projects from 48 states to participate in a 3-year pilot program, which is the first time that they are actually providing, it's $100 million of funding to these projects to communicate. It's the services, connected care services, that connect the healthcare provider to the patient. And it includes things like, is it possible for the healthcare providers to provide a subsidy for the patient's internet service? That may be eligible for funding. Their internet service may be eligible for funding, the healthcare provider. The connected care software platforms and some of the equipment necessary to make some of these things function can be eligible for funding. That's closed right now. The applications have been chosen and selected, but the Connected Care Pilot Program ends December of 2025. They're then collecting annual reports from these projects to determine if this was a success, and it may turn into a third program for RHC. So, anybody have any questions? Again, USAC.org, rural healthcare. We have tons of information online.
I have a question, if that's okay, if you could keep the microphone. Just from your view of seeing these programs that have been grant funded or even not, in terms of cities or states that are really addressing this issue the most, what have you seen to be kind of the most progressive?
You mean the connected care or all of the programs?
Just generally for internet access around healthcare. Do you feel like there's anyone that's kind of head and shoulders above the rest?
That's a very complicated question. So the application process for the Healthcare Connect Fund, which is the 65% subsidy, you can apply as an individual rural healthcare provider, or you can apply as a consortium, as an urban member. You can be an urban site as a member of a majority rural consortia. So the consortia applicants, I mean, some of them, I saw MUSC and University of Arkansas. These are these are the consortium lead entities for some of the biggest consortia, and some of them have up to 500, 700 members. Bulk buying, I mean, volume discounts. They really can command, a better situation for their members. Alaska is its own thing. Alaska basically takes up a good portion of the telecom program because, frankly, in the off-road frontier parts of Alaska, they're paying a lot for their access to broadband, whereas in Anchorage, it's way cheaper. So they're getting upwards of 99% discounts on some of their services because it's just so costly to get services up there. So the dollars go in one place. The number of sites are different statistics, and I don't have them off the top of my head, but I know that we have very large consortia in California, New England, and it's pretty equally spread across the country. In the telecom program, it's pretty limited to, keep me honest, Marco, because Marco actually reviews the telecom forms. It's a huge presence for Alaska. Very rural Texas, very rural New Mexico, very rural Georgia, very rural Arizona. Those are, because frankly, if the difference between the urban and rural rate is 65% or less, you're going to go with the Healthcare Connect Fund because there's more eligible for that fund anyway. If you're really paying significantly more, and there are still huge pockets in this country that don't have service providers who are willing to provide the services, well, then perhaps the telecom program is for you. Does that make sense?
Yes.
Great.
Thank you so much.
Well,
There's a comment in the chat also asking about the ACP program. I believe, noting in Virginia, you through Medicaid can get a free smartphone, and I'm pretty sure that is a reference to ACP.
Lifeline.
Yeah, Lifeline.
Yeah, right. But the other thing is just because we're in Mid-Atlantic regional area, UVA has a really, really big consortium, and started with the Rural Healthcare Pilot Program that started in 2007. So they're pretty established. So there's a pretty established consortia.
Fantastic. Bill, I don't know if you're able to, you are very godlike in this room right now.
Yeah.
I'd just like you to know that because your audio is so excellent. But if you're able to chat the links to some of those programs in the chat, I think that'd be great because then even the participants here can see it in their app.
Yep.
Great.
And unfortunately, I believe the way I came in, I do not have access to Q&A.
Okay, you're just on the Zoom. I see.
Yeah.
Okay. Like the Wizard of Oz. That sounds great. Okay, thank you.
try to cut and
Yeah,
paste.
Rebecca's gonna chat them in. Thanks so much. Okay, so what we've described is really one academic medical center's experience of trying to track the disparities in the surrounding community in terms of telehealth access, and trying to take a convening cross-sector approach to try to collaborate with our local groups to see how we can address those disparities. It's been exciting to see that there's a lot of excitement. We have a city, in Baltimore City, digital equity officer. We have a lot of potential funding around, so it does feel like a time where there's a lot of time to make an impact. There have also certainly been barriers. We've had turnover in a number of the external leaders who we've collaborated with, who's had enormous enthusiasm, potential, and then have moved on to different roles. So that's been a challenge. It's also been hard to know what are the right funding opportunities and what are the right partners. And we feel like it's been a little bit hard to feel or stay organized, even though there's a lot of enthusiasm. So we applied for the AAMC Tech Award around spending some time and energy thinking about how to thoughtfully convene some of the stakeholders with whom we're having one-on-one conversations. And so I'm going to present and a huge thanks to our telemedicine team, Emmanuel Patti, in particular for a lot of the work he's put into working on planning this event. I'm going to go through goals and a draft agenda, and we really welcome your feedback. I think some who are in Baltimore, we have invited to come to this, but really would like others' opinions on how to make the most of what we're planning. So we're going to be having a session in June. We timed this after the end of the Maryland legislative session, so we'd have a sense of where Maryland Medicaid telehealth would be. And we want to host this convening session, which will be a 2-hour virtual event on June 6th of local and regional stakeholders to discuss some of the existing efforts around telehealth equity in Baltimore City and partnerships for collaboration, with potential outputs being asset mapping, scaling best practices, policy planning, and collaborative grant applications. We want to synergize the efforts across these internet access, device access, literacy, health design, and policy frames that we've talked about, and then potentially create a framework that others could replicate. So what that will look like in practice, we have a time and date for the event, which is a really good first start. We have some topics we plan to cover with some of our local leaders. In advance of the session, we plan to do an asset mapping exercise. So of all the groups that we've invited, they'll be hopefully completing a form which will be sort of like a directory of contacts, current efforts, strengths, and needs, or potential opportunities for collaboration, so that everyone coming away with the event will have a directory of those working in this area. And then during the session, we hope to cover from our Office of Broadband and Digital Equity in Baltimore City, some of the needs that they've identified citywide, not just for healthcare, but across sectors. From our East Baltimore Development Inc., they had a Microsoft grant to do a needs assessment in East Baltimore around internet infrastructure. Again, not just for healthcare, but we will be hearing about their report. We will be hearing from our public library system about their device program. They have Chromebooks and hotspots. They have had trouble distributing them. They have more than they can distribute. So just learning from their experience, they've also done digital training, not specific to healthcare. And also learning from our nursing colleagues on a lot of the digital health equity work they've done. We're really excited to probably have I forget what it's called, but it's an artist who draws while you're having the meeting to hopefully... Dancing with Markers is the name of the company. So we're excited to have at least a visual to come out of the discussion, but would love any feedback if others have done similar efforts on how to best engage these stakeholders. Love any feedback.
Thoughts from the group? If you could build this in your own state or for your own organization, are these the types of folks that you would bring with? Who would you add?
Have you guys included K-12 school district organizations in your discussions? Has the digital disparity there influenced kind of your goals, and having them at the table, would that be helpful?
Thanks so much. That's a really great point. And I forgot to mention here community-based organizations and patients, which is so important. And we are trying to figure out exactly which community-based organizations and patient group to include in this event, but that certainly will be part of this moving forward. In terms of schools, I believe that East Baltimore Development Inc. in their East Baltimore map of needs included Henderson Hopkins Schools, which is a school in that 21205 zip code just north of Johns Hopkins Hospital. But I think it's a really important point, and one that I meant to ask this morning around, if we narrowly focus on digital health access, then we're potentially missing the opportunity to say, okay, what about social services? What about education? And kind of all of the reasons that a family and a household would need to have these services.
Fantastic presentation. I would include local EMS, the agencies as well, because I think the community paramedicine model is completely appropriate, urban or rural, even better urban because of the broadband connections.
Fantastic. Thank you.
It's a great idea. Anybody else?
Does anyone else have examples of academic partnerships? I know Arizona, I think, had a really cool partnership where their university was supplying internet to their like a geographic footprint around some of their buildings. I don't know if others have had examples of academic centers or other health systems providing internet or devices.
So glad Blythe is there, but we're very fortunate recipients of the FCC Connected Care Pilot Program. So we provide, that doesn't provide devices, but we've gotten other grants, and we provide devices and connectivity through that Connected Care Pilot Program to patients all across Virginia. So.
Excellent. And for those programs, do the patients get to keep the devices indefinitely because it's through the FCC? Or I guess when we think about device distribution, we get into a little bit of trouble about giving away devices.
Devices are not covered by the
Okay.
There are other grants that do cover devices, but we just fund the broadband connections and equipment to make those broadband connections functional. So it really is like up to the building, and that's it.
But I remember reading, I mean, we haven't worked with the Affordable Connectivity Program yet, but I understand, having read, they actually can provide a certain % of funding for devices for patients as well through that program, like 30% of the cost of a computer up to a certain price anyway. And then our devices are mostly used for remote monitoring, but it could be for long periods of time. And they are locked down devices that can only be used for healthcare related activities as opposed to Netflix, because we don't want to use the FCC's funding to be used for other purposes other than healthcare.
I think, was that Dr. Ruban
Yes, it
speaking?
was.
Karen, we absolutely need to talk about ACP program.
Bill, is there anything you want to elaborate for the group here?
Well, just that the devices in ACP are what makes it very different than other programs, somewhat lifeline, but ACP can provide up to $50 from the patient, $100 from the program itself for a device, and you can certainly get a functional smartphone for that price. So it's truly a telehealth device funded by the government and usable and for many, many things, healthcare just being one of them. So the ACP program is relatively new, and I think our USAC folks have already made several references to it. It's an excellent program. 46 million households are eligible. Only about 16 million are currently participating.
So we are currently, Shalondra Greenlee, NC Counts Coalition. We are currently working with our information technology department in the Office of Equity, the state of North Carolina, because of just that reason. Obviously, with net inclusion and the digital divide, we realize that you have to have a device and one that will be useful for the things you want to use. But the other part of equity in that is to not limit the individual being able to use the device only for one particular purpose, because in reality, it's a waste. Otherwise, it's a waste. So by having what we've seen that we've had to do as a nonprofit organization, partnering with the state, we know that federal funds are very restrictive. And so on the other side of that, we've looked for philanthropic funds that can either be an option for regranting, but also to purchase devices, so that way they don't have restrictions. So our push with ACP is for the subsidy and the connection and providing that resource, because there's about 30% of individuals across the state of North Carolina that could actually benefit from the ACP. But on the other side of that, with devices and digital literacy, we're trying to make sure that we have started to frame that into digital skills versus digital literacy, because that's an ongoing conversation of learning for everybody. And then the other portion for us in regards to connection with just educating and the universities is that we're trying to not create silos. And so in a lot of cases, entities like the libraries for individuals in BIPOC communities, or even institutions of learning, can be another form of government. And so creating that trust, building those relationships, and bringing all of those individuals to the table have helped us with our ACP outreach, but also helped us building the digital navigator and so forth for telehealth. Because for us, it starts with access. If they don't have infrastructure across North Carolina for those lines that stop at the door, they won't get on the computer. So it is truly a full cycle process for us, not just a one lane.
Fantastic. Thank you so much. I don't know why what you were saying was making me think of this, but there's so many foundations to the skills. In my own family, my mom's a physician, but she still needs my help to get on a telehealth visit. So it's, you can't necessarily tell who is digitally savvy and who is not. But there are those foundations of skills of just like being comfortable using a device, and then there's using those skills for healthcare. So I think we're, as an institution, at 72% MyChart enrollment. We're pushing a lot of online scheduling due to staffing shortages. In my primary care clinic, a lot of my patients who are living in East Baltimore and enrolled in our Medicaid MCO are doing a lot of online scheduling, and that's like an amazing access point. So helping to teach patients, how they can really have a more efficient healthcare experience when they have the patient portal access.
Do you know what device the libraries are that they
Chromebooks. Yeah.
I hate to say it like this, but therein lies the problem.
Yeah.
For those that don't know, because along with our census work, we are really trying to make sure we lift up language barriers. And for many of our population, that if they have a bilingual household, Chromebooks don't allow for interpretation. So here you have a device that the schools or our local governments are pushing out, but that can't be used as a resource for the family, and maybe they need that as a resource. So I guess my follow-up question would just be, have additional conversations in the Baltimore area, has that occurred of having alternatives, talking with those entities to see what additional resources that can be provided to them? Because I can imagine that might be one of the reasons why they haven't been able to get them.
Yes, that's a really great point. And I think we have a lot of evidence to suggest that smartphones is the preferred access point for our patients, and also that text messaging is a preferred access point for patients. And so figuring out how we can support them and using technology they're comfortable with, I totally agree with. Sarah?
I think another potential interesting party at this table would be area health education centers who have that crossover between bringing new healthcare workforce through pathways, but also continuing education and their work in communities. And so that could be a really nice synergy of bringing on folks and getting them interested in digital literacy and then that connection to healthcare, but also having that base of work that they're out in the community as well.
Thanks so much.
Anyone else? I'm trying to figure out how to take notes, hand the mic.
Yeah. If
and
anyone
the
could do all of
digital-
it, it's Rebecca. I think we have one in the back.
Okay, great.
I saw earlier you were talking about design, and I feel like for us, like we think the first thing is before digital literacy is easy design, that like nobody wondered if Candy Crush was gonna work and people needed to be digitally literate to use it. It was like just so easy, and that's what we always think is like the first level. And Epic and our shops, like Zoom, all assume you're a desk worker, you'll click through anything to get anywhere, and all that stuff. And so when I was looking at the people, I was wondering, like, you said that your HIT department probably was gonna be at the table for designing, but I wouldn't say they are used to designing for a patient in
Yes.
the middle of a rural place that just needs to click on a few things.
Yes, thank you so much for that point. I should have been a little bit more specific. We have a new user interface designer on our health IT team, and her skills are so powerful, and we don't yet know how to use them fully, but we had her meet with just 7 patients on work through our telemedicine platform, and she will walk patients through the workflow and talk them through kind of every piece of the puzzle, and she was able to come up with such helpful information from just talking to 7 patients. So I think trying to go to our forums for feedback that already exist rather than trying to recreate the wheel. So we have Central Soul, which has a Latino Family Advisory Board. We have a CRAC, which is a Community Research Advisory Council. So trying to think about how to leverage the groups that are already giving, community members are already giving feedback in other forums, and trying to figure out how to leverage those pre-existing groups, and maybe this user interface design expert, because just the one-time feedback isn't sufficient. You really need to walk patients through the task. We were at least able to go to a one-click join platform in August of 2020. So we have had the ability to text links from outside of MyChart since 2020, and that's been a huge help because our initial platform involved an app download that was not a very simple app download, and that was really a barrier for patients. So now having the ability to text a link to anyone has been really helpful. Great, so we discussed that. I think this is yours, Rebecca.
Yeah, this is my baby. We have folks in the room, I think, as well. So we are putting together a symposium for May 4th. May the 4th be with you. Telemedicine, A New Hope, where we're going to be talking about equity legislation and outcomes. And so please, we'll get it on the Matrix site. So please join us. It's free, no CMEs. But please come. Note that it is right before May 11th. And so this may be some of our last hurrahs to be able to speak as a group as to what we need and really look at these things carefully. So if you'd like to participate, come see me, and we'll be sending out invites if you'd like to join us.
Great. Well, appreciate everyone's engagement. Really great discussion.